Good day and welcome to this webinar on the evaluation and management of bone fragility in HIV. My name is Dominique Pierrot and I'm the science manager at IOF. I'm delighted to moderate today's webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker toward the end of this webinar. This being said, I have the great pleasure today to welcome Dr. Polyzois Makras. Dr. Makras is the director of the Department of Medical Research at the Hellenic Air Force General Hospital in Athens, Greece. He serves as a member of the IOF Committee of Scientific Advisors. He is a former president of the Hellenic Society for the Study of Bone Metabolism and the principal author of the Greek guidelines for both the management of osteoporosis and parathyroid disorders. Dr. Makras has published over 130 publications in peer-reviewed journals on bone, calcium metabolism, rare diseases, namely Langerhans cell histiocytosis, and bone loss in HIV-infected patients. Dr. Makras, thanks again for having agreed to speak. We are delighted to have you with us today, and we are listening to your presentation.
Thank you very much, Dominique, and thank you very much for this kind introduction. And I have to say that I'm very honored for being here, and I would like to thank the organizer for this honorable invitation. So we are going to talk about the evaluation and management of bone fragility among people living with HIV, and I will give you my option for this. This is the well-known conflicts of interest, and starting this presentation, I have to say that now HIV-positive patients are living quite longer. As you can see, the percentage of patients under the highly active antiretroviral therapy has been greatly increased during the last years, and this percentage has been raised quite a lot during the recent years. On the contrary, the deaths per patient have declined over time. So in the United States, let's say a 20-year-old patient that tested positive for HIV can now be expected to live into his or her early 70s, and I'm sure that his figure has been increased during the recent years. So talking about the average life expectancy in HIV-positive patients, you can see what was the number between 2000 to 2002 was around 56 years, and has been raised up to 72 years. It is quite close to that of the general population. And now you can appreciate from the left panel that we are talking about a middle-aged population, as more than 50% of these patients now are more than 50 years old. So they have all these conditions and illnesses that can be expected in this age range. So we can say that we have moved from a patient status, from a status where we have an acute disease, and this condition has shifted to a chronic condition with all the well-known risks to accumulate, such as the risk from chronic inflammation, the risk from comorbidities, and of course the detrimental effects from the highly active antiretroviral therapy. So we can have long-term effects on human health, and we can have effects on the cardiovascular system, on the liver. We can have a neurological impairments among these people. Some cancers are being increased regarding the prevalence. We have effects on kidney, and of course, we have the effects on the skeleton. And this is what I'm going to present you in my next slides. So the effect on bone strength in this disease is a multifactorial one. We have the well-known parameter, such as the gender, the low BMI, the toxic habits, and I'm talking about alcohol consumption and smoking. We have the nutritional factors, the low vitamin D, which is quite prevalent among these patients, and sometimes they can have an up to 80% and 80% of this deficiency among this population. And I have to say here that I'm gonna switch and saying that these patients, these subjects do not want anymore to be called as patients, rather than as subjects living with HIV. So apologies if during my talk I'm referring to them as a patient. So, besides all these well-known factors, we have other factors such as that are disease-induced, such as the heart, the hypogonadism, which is quite prevalent in this population, and almost 20% of male people having HIV are hypogonadic, and of course we have the co-infections such as hepatitis C. There are, as I told you, many factors that are affecting skeleton, and we have also the virus that can infect on not only lymphocytes, as you can see from this figure, but it can directly affect both osteoclasts and macrophages. And this can be done either by cell-free viruses or from cell-to-cell transport from T lymphocytes. So from the infection of B or T cells, we have an increased rank ligand together with a decreased OPG, and this has the well-known osteoclastogenic effect. And moreover, regarding osteoclasts, there is an increased expression of TRAB and cathepsin K, and this is because of these viral proteins such as TAT and NEF. And this has an effect in the osteoclastic micro environment with larger and more osteoclastic sealing zones. Moreover, the direct effect of the virus on the mesenchymal cells, which are the pre-osteoblastic cells, induce an early senescence together with the an apoptotic effect in the osteoblasts. And of course, there is another increase in some cytokines that they can induce osteoclastogenesis, while the factors, the osteoblastic factors such as alkaline phosphatase or RNX or bone morphogenetic proteins are decreased, their expression are decreased. And finally, the expression of PPR gamma is increased, and this leads more to adipogenesis rather to osteoblastogenesis. Another effect of the disease is that on the gut microbiome. So the chronic HIV infection can induce microbial dysbiosis, which can then lead to a decreased microbial diversity and has an effect in the functional capacity. And this in turn increases the permeability of the gut barrier, and that can lead to depletion of T cells. This is a cascade of events, and this can further induce the activation of the innate immune system, leading to an increased secretion of pro-inflammatory cytokines, and leading finally to osteoclastogenesis and bone resorptions. And moreover, the treatment per se can have an effect on microbial dysbiosis and the decreased microbial diversity and functional capacity. Going to the bone micro environment, and namely to the bone microstructures and histomorphometry, we can say that there are alterations in volumetric BMD, and these alterations predominate intravehicular rather than cortical bone, and this is evident across all ages with the exception of younger and elderly subjects where in whom a defect has been observed in cortical thickness. And regarding the bone turnover of these subjects, among untreated population, we can observe a low bone turnover with a defective formation and mineralization. However, when a heart is administered, then there is an increase in bone remodeling, but there are still mineralization defects and increased osteoid volume. So this is a schematic presentation. It's just a picture of myself. If we want to schematically report the BMD, the follow-up of the BMD through the lifespan of this population, we can start from this part before HIV infection. It has been reported in several articles that people living with HIV have a lower BMD even before the HIV infection compared to the uninfected individuals. And this is because of the increased prevalence of toxic habits, of low BMI and low BMD. And after that, and following the HIV infection and during the untreated period, there is a slight decrease of BMD, which further goes down at least during the first 1 or 2 years from heart implementation. Thereafter, and during the long-term treatment with heart, there is a slight increase of BMD and stabilization thereafter, and then the BMD follows the well-known presentation of BMD during the advancing age, and this is pretty much comparable with the rest of the population. And as you can see from this very nice review, the decrease that can be that we can see during the implementation of antiretroviral therapies, it's probably more than that observed in early menopause or during an implementation of aromatase inhibitors, and is comparable with the BMD decrease shown when we give glucocorticoids to a patient having, let's say, a chronic inflammation. So we can see, at least for the first years, a decrease between 2 to 3%, and thereafter there is a stabilization. And of course, there is a greater decrease, and I'm going to speculate more on that whenever we are using this tenofovir prodrug there, namely the TDF. So we have an around 7-fold increased risk of low BMD and an almost 4-fold increased risk of osteoporosis, with a nearly 5 times increased risk in the hip fracture incidence, and this is quite independent of sex, age, and smoking. And the prevalence of osteoporotic fractures can be up to 60% higher among this population, and it can occur more or less 10 years before that from the general population. So these people can have fractures starting from the age of 40 years old. The bad thing is that almost 6 out of 10 believe that they are not at an increased fracture risk, and younger patients can still have a detrimental effect on their big bone mass because the administration of heart can adversely impact on their BMD. This is a figure that I'm showing you in order to, of course, to see that around 40% of patients, and now I'm referring to this relatively young, mainly male population, and you can see almost 40% of them have a decreased BMD in the mainly in the osteopenic rather than in the osteoporotic range. But the reason for showing you this picture is that, as you can see from here, people that have sustained a fracture have, of course, a lower BMD than those without a fracture. However, if you can see the mean T-score, it's not that very low. As you can see, it's marginally osteopenic, although these patients have sustained a fracture. As I told you before, there is, of course, a great effect of heart treatment on the bone and the bone health. And starting to elaborate more in this topic, I have to say that these are more or less the majority of heart classes that are being used in the treatment of HIV. We have the nucleoside reverse transcriptase inhibitors, namely the NRTIs. We have the non-NRTIs, the protease inhibitors, the integrase inhibitors, the fusion inhibitors, and the chemokine receptor antagonists. And I'm giving you some examples from these classes. And the standard of care usually in treatment-naive patient is a combination of two NRTIs, and usually typically what is used is a combination of tenofovir with emtricitabine plus one non-NRTI or integrase inhibitor. And having said that, I'm showing you this this slide where you can see that the administration of heart is correlated with a BMD loss that can be up to 6% during the first 1 to 2 years from onset. This is from the onset of treatment. It is very consistent throughout all the classes. It is quite curious and quite peculiar because with heart, good things happen. I mean, we have an increase in lean bone mass. We have increased testosterone levels among males, although BMD still continues to fall during the first 2 years from the administration. And beside the muscle mass, which is increased, we have an improvement in cytokine levels, which, of course, they can lead to osteoclastogenesis. So, although we have these things, BMD continues to decrease even after first and second line of treatment. What we can see, and probably give an answer for this peculiar finding of the BMD decrease during the first 2 years, is that the bone remodeling increases following the treatment's onset, especially with TDF. And there is an initial increase in osteoclastic function, followed much later by an increase in the function of osteoblasts. So we have a catabolic window, at least for the first 48 weeks, and we have a stabilization thereafter. I'm sure that the older in the audience will remember this picture, and this picture more or less reminds the anabolic window we have, for example, with teriparatide treatment, but we have the opposite, let's say, the opposite effect when we start treatment. And as you can see from this schematic presentation, we have an increased function of osteoclasts immediately after the administration, the initiation of heart treatment, and then the function of osteoblasts is increased thereafter, and then we have a new equilibrium, a new status following the first year of treatment. And probably this is the reason for the decrease of BMD during the initiation of heart. Apart from the BMD loss during the first years of treatment, we have also an increased risk of osteoporotic fractures among HIV positive subjects, especially not with all the classes, the heart classes, but we have that especially with TDF, and I'm going to elaborate on this specific agent and the boosted protease inhibitors. I told you that there is a difference with tenofovir disoproxyl fumarate, which is a prodrug of tenofovir, and we have this specific findings with this kind of treatment. We have hypophosphatemia, and this is due to the dysfunction of the renal proximal tubule, leading to bone absorption in order to maintain phosphate levels. And in addition to that, we have high levels of vitamin D binding protein, which leads to a functional vitamin D deficiency, although we may have normal levels of 25-hydroxy D, and this can lead, of course, to a secondary hyperparathyroidism. And there is a decrease of BMD during the first 24 weeks, and this is up to 3% more than other antiretroviral agents. And there is a further aggravation until 2 years of treatment. And when we switch from a TDF-containing regimen to a TDF-free one, we can see an improvement in bone markers. We can see a decrease in bone remodeling and decrease in sclerosing. Sclerosing, as you probably remember, is an agent, is affecting the osteoblastic function, and this can lead to increase of BMD. So we have some switching options from TDF to, let's say, another antiretroviral agent, such as Bacavir, which is also an NRTI. And as you can see from the left panel of this slide, there was a slight, although not significant, increase. However, when a TDF was switched to another agent and integrase inhibitors such as Raltegravir, we may have an increase in BMD which is up to 3%. And this is a great increase in this single arm study. As you probably remember, we can have this kind of increases when we administer, let's say, anti-osteoporotic agents to patients suffering from osteoporosis. So we can have some switching options with this specific regimen. And as I spoke for tenofovir, I have to tell you that tenofovir is a negatively charged ion. It's called it's a negatively charged particle, so it has low bioavailability in the plasma. So it needs a prodrug in order to get into the circulation. Such a prodrug is TDF, the tenofovir disoproxyl fumarate, which can have bioavailability in the plasma. It enters the plasma, has a short plasma half-life time, and then can enter to lymphocytes in order to inhibit the function of HIV. So with this prodrug, a lot of tenofovir is released in the plasma and then can be taken up by the organic anion transporters and then cleared by the circulation. However, we recently, there is another prodrug that has been developed, namely the TAF, the tenofovir alafenamide, which has almost 10% of the concentration of TDF, has more than 90% less tenofovir release in the plasma, and although it makes the same work regarding the HIV inhibition, there is lower tenofovir to be cleared by the circulation through the renal tubule cells. So, with this regimen, we have the same decrease in the function of HIV, although with much less drug. So by switching from a TDF regimen, TDF based regimen to TAF, you can see that there is a lower decrease of BMD compared to those who have continued receiving TDF. So less BMD loss with TAF, and thus that was maintained at up to 96 weeks, although we have no further decrease after week 48. There are a lot of algorithms that have been developed in order to describe how we can manage this population having HIV, and I'm very fond of this algorithm, although there are many others algorithms that describe the management and the evaluation of these people. And as you can see, whenever we have a young adult, younger than 40 years, probably we don't have to screen him or her. However, we have a 40 to 50 years old subject. We should calculate the fracture risk by FRAX, and whenever we have a low FRAX score, then we can ensure adequate calcium intake and vitamin D levels, and we can give some lifestyle advice. However, whenever we have an increased FRAX score, more than 10%, and this algorithm is using the US FRAX thresholds, or we have a FRAX score more than 20%, we should exclude secondary causes of osteoporosis, low BMD, and then continue with treatment. Although if we have a lower fracture risk, we can continue with DEXA measurement, and whatever we find, we can either ensure adequate calcium and vitamin D intake and lifestyle advice, or continue with treatment. And of course, we should measure BMD with DEXA in all postmenopausal women having been having HIV, or men older than 50 years old, and that and use the BMD in order to calculate a FRAX score. As I told you, there are other also recommendation for screening and diagnosis, and I urge you to read the European guidelines. As you can see from these guidelines, you should consider DEXA measurement in any person above 50 years old, or within the postmenopausal range, or high risk of falls, or with increased FRAX score. I'm not going to elaborate more on that, but I'm showing you this picture in order to urge you to rule out secondary causes of osteoporosis, and to use lateral spine X-rays at least as a baseline, as if you find any morphometric vertebral fractures, then you should continue by giving anti-osteoporotic treatment in these people. There is a slight problem with FRAX, the estimation of fracture risk with FRAX, as FRAX probably underestimates the fracture risk among people living with HIV. As you can see, there was a less accurate estimation among people with HIV compared to those without HIV. And based on their FRAX score in this specific cohort, almost 97% of HIV positive men with an actual fracture would not have been flagged for treatment. So we should keep in mind that whenever we are estimating fracture risk with FRAX among these patients, we should always tick the box of secondary osteoporosis, as it modifies a bit the FRAX score and increases a bit the FRAX score, and is very helpful for the what we're going to do further on with these patients. We try to compare and to see how FRAX is doing, how FRAX is doing in the Greek population, in the Greek HIV population. We didn't find any difference between the cost-effective 10-year major osteoporotic fracture probabilities among this population, the uninfected population, and that was also evident in the hip fracture probabilities, although we found a higher cost-effective thresholds for females more than 70 years old. And given these findings, we are stating now, at least in my country, that there is no difference in FRAX-based cost-effective intervention thresholds either between people living with HIV and the uninfected population. And these are the thresholds that we're using in order to implement treatment simply by the estimation of FRAX. Going further with the treatment options we have for osteoporosis in this population, I should state that we have not that many studies, and the majority of studies had not that many patients, starting from 40 up to 80 patients, as we can see from the main published studies with alendronate, and of course we don't have any data regarding the decrease in fracture risk. We have only BMD data, and from this data we can extrapolate what we should expect from the implementation for alendronate treatment. And as you can see from this table, we can expect an increase both in lumbar and femoral and hip BMD. And this is also the case with zolendronate, and we have these published main published studies that I'm showing you in this slide. As you can see, we have also low numbers between 30 to 40 patients, and I have to say that also zolendronate has been used in order to alleviate the expected BMD loss when we are implementing antiretroviral treatment, and this is also the case with alendronate, and alendronate was also used in this manner in order to improve and not to have that great BMD loss when we start antiretroviral treatment. Having said that, we should keep in mind that the majority of studies have used either zolendronate or alendronate. We don't have any studies, at least in my knowledge, with ibandronate, and I think there is only one study with risendronate among hypogonadic males. And we don't have any data besides some case studies. We didn't have any data with teriparatide and denosumab until recently, where we have done a study that I'm gonna present you in the next few slides, where we compared denosumab versus zolendronate for the treatment of low BMD among male subjects. As you can see, we had three groups: one assigned to zolendronate, another one assigned to denosumab treatment. That was only a single year study, and we also have a control group in order to see what heart is doing in BMD during the follow-up of the disease. And these are the three groups. You can see we didn't have any very low BMD, neither nor increased FRAX score, although the treatment groups had to receive treatment, had to initiate anti-osteoporotic treatment. And these are the findings. As you can see, we had a slight decrease in the control group, although there was a great increase in the BMD at the lumbar spine, both with the denosumab and zolendronate, and that was comparable, although there was a greater increase in BMD at the femoral neck with zolendronate, and this is something that is probably of clinical significance. Another finding in this study that has probably to be discussed is that in this particular group, we didn't find any acute phase response, although we were expecting an around 50 to 70% of this phenomenon. And this was also in another study by Boland and colleagues, where there was only a 10% prevalence of incidence of acute phase response. And this is probably something with a clinical significance, probably because either HIV, the disease itself, or the heart can have an effect on gamma delta T cells, which are responsible through their number and their activation for the acute phase response. So probably something that should be confirmed in other studies, and I'm talking about zolendronate, of course. And these are the individual responses in this study, and I would like now to conclude this presentation by saying that HIV patients are now living longer. They have an average life expectancy quite close to that of the general population and present long-term effects from all aspects of the disease. And I talked about the bone disease. There is an increased risk of bone loss and fractures, and this is 10 years earlier than the general population. And untreated HIV bone disease is a low turnover, one becoming a high turnover after heart initiation. And a highly active antiretroviral therapy is possible to further reduce bone loss during the first 1 to 2 years, especially with tenofovir disoproxil fumarates, although we have some switching options, even with tenofovir with another prodrug, as I talked about it. And this bone loss stabilizes after the first 2 years. We have some therapeutic options in order to treat osteoporosis in this population. We can use either alendronate or zoledronic acid, and probably we can now use denosumab to treat these patients, although we don't have many data for many years. And when calculating FRAX score, we should always tick the box for secondary osteoporosis, as HIV disease should be considered as a reason for that. And with that, I would like to thank you very much for your attention, and I'm ready to answer your queries.
Thank you very much, Dr. Makras, for this very comprehensive presentation. I'm sure it was greatly appreciated by our attendees. And now can you maybe just come back one slide? Now I would like to move on to a question. Maybe I will start with this one while people are typing their question. I really encourage attendees to type their question into the question box. Dr. Makras will be happy to answer your questions. So, Dr. Makras, maybe the first one, regarding one of your last slides. So, do you think now that denosumab treatment can be readily used in this population for more than 1 year? Now that you have done the study,
yes.
What is your?
Thank you for this question. I think that at least we have another option now. Of course, denosumab has been used for other cases of for secondary osteoporosis, and we use that at least for 1 year in this population without any adverse event. I didn't elaborate more on that. We didn't have any adverse event, and I'm sure that there would not be any adverse event if we continue treatment with DMAP. But of course, we should keep in mind that you can give denosumab up to a duration of time. However, when you stop denosumab, you should not discontinue treatment without giving something else. So probably we can have a treatment strategy, a new treatment strategy starting from denosumab for let's say 1, 2, or 3, 5 years. I don't know how many can be are needed for a patients. However, when we stop denosumab, we should give an bisphosphonate exactly as we're doing with the rest of osteoporotic patients, and we should probably give either zoledronate or alendronate for at least 1 year. So yes, probably we can use now denosumab treatment in this population.
And I'm sorry if I missed it in your presentation, but did you measure bone markers in your patient treated with denosumab?
Yeah, well, we have measured, but we are not, we were not elaborating in the paper with the bone markers, but we have done that we have done that after the publication in some specimens that we have, and there was a similar decrease in bone markers with denosumab without any difference from the general population. I don't know whether that was the question.
Thank you.
But we're referring to bone markers in the publication.
Now maybe a broader question. Can we prevent osteoporosis among people living with HIV?
Well, yes, probably we can do that, but we don't have any specific things to do. We should keep in mind that these patients are possible to have a low BMD level, so we can always ensure adequate vitamin D intake or exposure to sun, let's say, we should ensure adequate calcium levels, and we should urge them not to smoke or to consume alcohol. So we can do all these measurements that we are suggesting to other people in order to prevent osteoporosis. Whenever we are talking about the prevention of osteoporosis, when we are giving when we're giving heart, when we're giving treatment for HIV, probably maybe we can choose bone-sparing agents with the less expected BMD loss, such as, let's say, a TAF compared to TDF. Some clinicians are using, as I told you during my presentation, either an anti-osteoporotic treatment during the initiation of heart, but I don't think that this can be said as can be recommended to all the persons having HIV. So probably we should stick to those measurements, the general measurements, the general measures that we are taking about the prevention of osteoporosis in the general population, and then judge according to the patient that we are having in front of us, and we are dealing with his or her BMD.
Thank you. There is a question from Dr. Morin. She is asking if we use FRAX for fracture risk assessment and enter secondary cause of osteoporosis to account for the positive HIV status, as you mentioned, there is not much added value to do it if we also input the BMD result. She's asking if there has been any consideration to entering also rheumatoid arthritis instead of secondary osteoporosis.
That's a very good point, and it's exactly as said. Whenever we are using BMD in FRAX, it doesn't matter if we put if we tick the box of secondary osteoporosis, because if you are using BMD, then FRAX already estimates that the secondary osteoporosis has been counted with the BMD. So there is no added value at all if we have a BMD. However, there is added value whenever we don't have a BMD measurement. So if you just tick the secondary osteoporosis and you don't have a BMD measurement, then there is a value for doing that. It is a good point. I mean, if we just put rheumatoid arthritis, although I cannot recall any recommendations or any studies that have done that. So I cannot. This is probably a good thought, but has not been done, at least in my knowledge. So I do not recommend
that. Thank you. Another question. Should switching treatment be discussed within a multidisciplinary team, or is it just a decision taken by the specialist, the infectious disease specialist?
Well, I definitely agree that let's say the bone health of this specific population should be handled through the multidisciplinary team. What is, what is now the case is that, at least in my country, usually the infectious specialists are dealing with the treatment because what they want is to have to eliminate the risk from the disease itself. However, as I saw you, these patients are now living longer and can have all these adverse events that can take place with advancing age. So yes, whenever we are giving an infectious specialist is giving treatment for HIV, should also consider other aspects of the subject's health, such as, let's say, the kidney function or the bone health. So can, of course, ask within a multidisciplinary team what we can do in order to, let's say, improve in order to not to have all these adverse events from the implementation of treatment per se. So yes, I agree. A multidisciplinary team is needed, and this is the case for all chronic conditions. I think you probably agree with that.
Absolutely, yeah. I think we do not have any more questions, so I think it's time to conclude. And I would like, no, there is one final question, maybe. Dr. Al-Makbali asking if there is any time limit when to start screening for osteoporosis after initiating heart treatment.
Well, as I said in one of my slides, there are a few cohorts that have used either zolendronic acid, zoledronate, a single infusion of 5 milligrams of zolendronate, or a short course, if I remember well, it was 14 weeks of zoledronate, in order to alleviate the decreasing effect on BMD. And this is something that can be considered. And I think that it cannot be given as a general recommendation. However, if we have, let's say, a marginal BMD, it is an option that we can use in order not to pass from, let's say, an osteopenic status to an osteoporotic status, and then having to treat osteoporosis. Although I think that we have to do some prospective studies in order to see whether this kind of therapeutic approach, is of value. I'm sure that it could be of value regarding BMD. However, I'm not sure what will happen regarding the fracture risk. Probably we will sustain BMD, we will have a stable BMD, but I'm not that sure that we'll have a difference in fracture. So we have to think all the adverse events from treatment, and of course, the prospective studies are needed in order to confirm that action.
Thank you. So now I think it's time to conclude. And I really would like to thank all of you for your participation in this webinar. And we hope that you enjoyed this session. We will post the recording of this webinar on the IWEF website, and you will receive your certificate of attendance and the link to the recording by email tomorrow afternoon, European time. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And if you have any questions, comments, please do not hesitate to contact us at webinar@osteoporosis.foundation. Thank you again, Dr. Makras, for your outstanding talk. It was really appreciated. And goodbye to everyone.
Bye-bye.